interesting, but
This theory has been developed as a dialogue between me and the Dr. Spera, because I had asked him some pointed question and he came up with some interesting answers. So we're going to be looking at three things that are much more focused, but theoretically very important. And whether we get positive or negative answers are going to be very helpful, not only for the trial, but also for the things that we're planning to do in that other project. So this is the thing that we want to work at, and we can expand from that as we move along. But we have to start somewhere. You saw, we can't look at all those pathways.
Sure.
It's just not possible. Even if we could.
well, we could. It'd be expensive and time consuming.
Well, the truth is, I want to call, this guy is in Edinburgh, is in Queensland, Australia. Is the Department of Molecular Medicine, Edinburgh. No, it's an Australian guy and an English guy. Okay, so the guy in Scotland is the main author. I'm gonna call him. I'm gonna ask him if I have slides. Would he be able to give us? And I give him because these guys a lot of these people are scientists. They're not doctors. They're not patients.
Right.
If I have, they're always looking for a trial that has patient with histories that you can correlate the clinical history to the finding. Even 20 slides, if I can send him 20 slides and he can give us this immune cell gene signature on these 20 patients, for instance, over 3 times, and he can validate on this trial just that. And the next time we do this trial, we're going to involve him again. We want to do, initially when I started, it was all about looking at CDK4/6 and I picked 3CA pathways. In reality, the story is all about immunotherapy, because both drugs, in retrospect now, 2 years later, have an effect on the immune system. So if we go back with data on the tumor microenvironment in the breast, it's going to be much better. It's not in the protocol. I don't know how we're going to get that done, but we can do it sideways. We're going to get them some data about pathways, expression, etc. But if we can get to them and say, look, what we're finding is that when the patients were responding, what we're finding is in the tumor microenvironment there is this immune response because, and I have a couple of articles that already looked at that, because these two medications actually cause the tumor macrophages to move out, the myeloid suppressor cells not to get into the thing. And maybe lowering of this gene and lowering of that gene, and you get a proliferative T cell come in that reacts against the cancer. Even if it happens 40% of the time, nobody's looked at that before. Nobody has that data.